There is a female-to-male ratio of about 7 to 1, especially postmenopausal women, due to hormonal changes and iron deficiency anemia. The primary location of the burning complaint is the tongue, usually the anterior 2/3. However, more than one site is often involved. In addition to the tongue, the hard palate, lips, and gingiva are frequently affected. Pain is most commonly described as burning or hot, and its intensity can vary from mild to severe. BMS typically has a spontaneous onset and can last from months to several years. The pain pattern may be irregular, often increasing toward the end of the day. Although a chronic unremitting pattern is usual, partial remission has been reported in about 1/2 to 2/3 of patients. Associated symptoms with the burning sensation of BMS include dry mouth and thirst, although there is no evidence of decreased salivary flow in most patients. Patients may also experience restlessness, irritability, anxiety, depression, and a decreased appetite. Facial pain and pain at other sites, altered taste, usually a metallic taste, and TMJ symptoms are also common. Aggravating factors include personal stress, fatigue, and specific foods such as acidic, hot, or spicy items. The differential diagnosis of primary BMS is secondary BMS. Why? Because to get a definite diagnosis of primary BMS, which has a neuropathic origin, you must exclude all causes that lead to secondary BMS, which are local or systemic pathological conditions. This is important as the treatment of primary BMS is different from secondary BMS. Diagnosis of BMS involves history and clinical examinations. Factors like hot, spicy foods, tobacco consumption, alcoholic beverages, and mouthwashes containing alcohol are considered. Products high in acids such as citrus fruits and juices are also reviewed. Tests like CBP, serum iron, and serum folate are done to exclude iron deficiency anemia and serum vitamin B levels. Allergy tests such as the patch test are performed by applying the material directly to the skin and observing the response. These tests require a longer time for the reaction to occur, usually at least 48 hours, but sometimes 4 to 5 days. Oral swab and culture, biopsy, and imaging tests are conducted to detect any lesion that might compress the sensory pathway or cause irritation, like a cyst or tumor. When all history, clinical examinations, and lab findings reveal normal results, we know we have BMS. BMS pain can last for months or years. Some people feel constant pain every day, while for others, pain increases throughout the day. For many, the pain is reduced when eating or drinking. We assess that a patient has burning mouth syndrome when we get normal lab findings, make a differential diagnosis, and exclude all disorders that cause a burning mouth sensation. Because burning mouth syndrome doesn't have any detectable cause or pathophysiological factor, it is just a psychological disorder. Treatment for burning mouth sensation when the cause is known involves addressing the local or systemic factor. Estrogen was used to overcome BMS in postmenopausal women, but it is not used nowadays due to evidence of causing uterine tumors. When the cause is unknown, treatment includes tricyclic antidepressants like amitriptyline, ranging from 10 to 150 milligrams, and nortriptyline, from 25 to 100 milligrams. Benzodiazepines such as chlordiazepoxide, 5 to 20 milligrams, and clonazepam, 0.5 to 1.5 milligrams, are also used. Anticonvulsants like gabapentin, 300 to 1600 milligrams, and carbamazepine, 100 to 1200 milligrams, are options as well. Capsaicin cream, 0.025 milligrams, applied 4 times a day or as a mouthwash, can be effective.